Ladies and gentlemen, hello, welcome to our session here this morning titled Pharmacy as an Investment, Harnessing Data to Maximize Patient ROI. So today we're going to take a discussion, I think, in a direction that we don't really talk a lot about. And I'm going to try to contain myself because this is a topic for which I'm very passionate about. I have two of my pharmacist colleagues to my left, and we're going to really start the discussion before we get to intros. And I want to put an idea out there for you all to really start thinking about, and this is going to guide the dialogue that we have today. The question that we're going to try to answer, going to talk about is, who owns the ongoing patient success, and who is accountable for the ongoing well-being of chronic care patients? It's really, more simply put, who in our healthcare ecosystem is accountable to the medications that patients take actually working, okay? When we talk about pharmacy in the US healthcare system, the dominant point, the dominant topic is the cost of medications, okay? We question, where can we get this drug for cheaper? How do we source it for less money? How do we reduce our cost? You've got Amazon Pharmacy, you've got Mark Cuban's Cost Plus Pharmacy, you've got the debate over 340B pricing and getting drugs internationally. Obviously, the administration and every administration before it, we all talk about lowering prescription drug costs. That is the only thing that we talk about primarily when it comes to pharmacy. How expensive is the drug and how do I get it for less money? As I'll touch on in my intro, one of the roles that I have, one of the hats that I wear, is that I do employer benefits consulting. And I advise self-insured employers on how to manage their pharmacy benefit, how to set it up, and how to manage their pharmacy benefits for the employees that they support and serve. And I pose this question to them when I speak to them and when I do my consulting work. I ask them, if I could get you a 50% discount on the branded medications or the drugs that you're paying for your employees, would you consider that a good deal? And it's basically unanimous. They all say, yes, absolutely. I'll take a 50% discount. That's more than I'm getting now. Please give me that 50% discount. I then follow up that question with another question. Okay, what if I could get you a 50% discount on a medication, but the medication doesn't work? Is that still a good deal? Do you still want that deal? And then similarly, nobody raises their hand. Nobody wants that deal. And so for us to be exclusively fixated on the cost of a medication and not put any resources towards medications actually working is illogical. It makes no sense. And right now, our healthcare system, we're not really doing anything to manage medications in a way where we're holding those drugs accountable to their efficacy. Bear in mind also that drugs, we don't take a drug just to celebrate the discount we got for it. And those medications also have collateral damage that they can cause. They can cause issues. They can cause adverse effects. They can cause death. And so what we're going to touch on is that very issue and the fact that we're obviously biased, but we collectively, and I think most people would agree that the pharmacist is
president of our insights business, which is our real-world data solutions business, servicing all aspects of the healthcare ecosystem.
Good. Are we good?
Yeah.
How about now? Can you hear me now? Okay. So I was saying that we're biased, but we believe that the pharmacist is the most appropriate healthcare provider, not the sole provider for this, but the most appropriate leader and healthcare provider that can own this. We're going to talk through some of the payment models and how pharmacists are paid and reimbursed and whatnot, but the reality is the pharmacist holds the key for delivering pharmacy care in a way that is cognizant of the cost of the drug, but puts emphasis and attention on this notion of the drug should work. We should be caring about the outcome. So, Chris Antipas, I'm a pharmacist, and I'm president of Paragon Pharmacy 360. We're an independent specialty pharmacy located in Pittsburgh, licensed 50 states. We have a second location in Southern California. And at Paragon, we are a specialty pharmacy, but we're also a technology company that is attempting to solve this issue and other issues related to engaging with patients, monitoring those patients, and intervening when we identify an opportunity to address a medication-related issue. As I mentioned, I also do employer benefits consulting, and as I'll touch on, it kind of informs the perspective that I have on the payer space, the payer landscape. So I have my two colleagues with me. I'll let Megan and Stefan introduce themselves, and we'll keep going.
So, hello everybody. My name is Megan. I'm a transition of care pharmacist at St. Bernard's Medical Center. Just a little bit about, it's a little bit different than what Chris and Stefan do, but I actually work with patients on the acute care side. So St. Bernard's is around 450 acute care bed hospital. And for us, we are servicing Jonesboro, Arkansas. We service majority of the Northeast Arkansas, including the borders states as well. So Missouri, Tennessee, sometimes we get Mississippi as well. So for myself in my role, I focus in on patients, ensuring that they have a safe discharge from the hospital. That includes providing extensive counseling on any new medications, access for patients on their medications, and be able to look ahead outside of their just acute care, but looking into their chronic disease state as well, making sure that they're able to continue getting their medications long term. My team it started out with just myself, honestly. It's only been about a year, but I was solely taking care of the whole hospital. We have since expanded with actual team. So I have another pharmacist and two transition of care technicians that help us service these hospital.
Yeah, great. Well, good morning. I'm Stefan Mizmakowski, and I'm the Director of Pharmacy Operations at Innovative Hematology. At Innovative Hematology, I oversee two different pharmacies. So we have a Indiana Hemophilia and Thrombosis Center pharmacy, which is part of our HTC, and we treat patients all across the state of Indiana. We're the only federally recognized HTC in the state of Indiana. And then we also have Indiana Blood Works, which is another pharmacy that we treat patients that we use non-340B medications for, and we do gene therapy preparations out of that pharmacy as well. So I've been practicing as a pharmacist for about 26 years. I've had 22 years in the community practice setting, most recently overseeing about 90 stores. And I am honestly just as busy, if not busier, at Innovative Hematology with all the things and different projects that we have going on.
Great, excellent. So I'm going to touch on this notion of therapeutic outcomes. We talk a lot about outcomes. And I mean, even the last session with all those, tech organizations up there, we talk about outcomes. And yet there is this disconnect when we really zoom in on pharmacy. We focus on one statistic on pharmacy that has all of the attention. And that statistic is adherence, okay? We talk about the importance of medication adherence. And we talk about adherence like it's an outcome, okay? I wish I could say this to the entire room, to everybody here, to the entire, hotel, to Washington, D.C. The reality is that medication adherence is not an outcome. It's a means to an outcome. If you take your medication, you might get better. Maybe you're probably gonna get better, but you might not get better. Okay? When drugs are evaluated in a clinical trial, by show of hands, how many of you know of any drug in a clinical trial where 100% of people that took the drug had the benefit from it? I don't think one exists. okay? So to assume that medication adherence is what matters is another fallacy. It's like it doesn't make sense, okay? Unfortunately, the system has latched onto medication adherence, and we've attached all kinds of incentives to it. And what's even further insane, in my opinion, is that we monitor adherence by a claim, okay? So we're pushing patients to get 90-day supplies of medicine so that we can win the calculation war and maximize the incentive that we're going to get over medication adherence. We obviously know, and when you pause and think about it, that just doesn't make sense, okay? We need to ensure that the medications are taken. Yes, we do need to make sure the patients are taking the medications that are prescribed to them. But taking the medication appropriately is also another very important point. How is the patient taking the medicine? A lot of what we do in the specialty pharmacy, we're dealing with complex drugs. These are, they're very sensitive from a supply chain perspective. They got to be refrigerated and stored and handled appropriately. They're often self-administered products, so they're injectables. So how the patient stores the drug affects whether that drug is going to work for them. How they administer the drug is going to affect whether it works for them. Not to mention the dosage or the molecule itself being appropriate. So when we look at some of these statistics, our aim and our objective should be to get the medications to maximum efficacy, and when we have signs or indication that the drug isn't working, we, number one, have to be looking and listening for that. When we see that, we should be doing something about it, okay? And I think that the other interesting point, transitioning to this the comment I made earlier about the role that the pharmacist plays in all of this, think about your own personal experience when you go and see a doctor, or maybe think of a loved one that goes and sees their physician, okay? It's one thing to talk about on stage this kind of utopian viewpoint of how healthcare works. We know that's not the reality, okay? When we go back to our lives, we realize that the social determinants are not just this concept. It's actual reality when patients have to go to their doctor and maybe they have issues getting transportation, all these variables. But think about your own personal journey with healthcare, yourself or a loved one. You go and see your physician or your mid-level provider, if you may not be able to see a physician, and you get X minutes with that provider. On the best case scenario, you're getting 30 minutes, maybe 45 minutes if you're lucky with that provider. Most cases, it's a 10 to 15 minute interaction with that provider, okay? You're given some orders and you leave. And you may not see that provider for 6 to 12 months. How often does that provider call you to see if the regimen they prescribed for you is actually doing their job? This just doesn't happen. If anybody sees it happening out there, let me know. But maybe if it is happening, it's happening less than 1% of the time, or at most maybe 5% of the time. That's not how it works. Yet, those patients that are prescribed the medication, keeping in mind that medications are the number one tool we use to control chronic disease, both acute and chronic conditions are managed by meds. The pharmacists, we touch that patient every month. Maybe, and oftentimes, more often than a month. So that reality puts the pharmacist in this position to be the primary party that holds the responsibility of making sure those medications are effective. Megan's going to touch on her experience and her perspective from her setting for how a pharmacist, like what the role of the pharmacist looks like from her perspective, and maybe give us an example.
Yeah. So it's just a little bit, like I said, we have a small team that covers a whole hospital. So for us, being able to touch every single patient is really difficult with us right now. We don't have the resources. So one of the nice things that we utilize is actually Inovalon's clinical surveillance board. So we use those to pick out the patients. If they hit certain criterias in our customized rule base, it alerts us to go see these patients. the nice thing too is that we can differentiate what is actually needed. So a good example is our high cost medications. One of the medications I focus in on a lot is not so much a chronic medication, but an acute medication called Dificid. It actually does treat C. diff infections, and if you've ever seen a patient who has C. diff infections, it is terrible to watch the patients, especially with them managing their symptoms. So for us, when we're seeing a patient getting started on this medication, our team is already working on getting the access that the patient needs before the patient even leaves the hospital. We're trying to look at what is their insurance is covering. If it needs a prior authorization, we are going ahead and getting that prior authorization started. If we have issues about getting access, we have our meds to bed team that can actually provide the medication before the patient even leaves the hospital, so they can actually have the medication in hand. And if all else, if it's a financial thing, we actually do work with the manufacturer patient assistance program to be able to provide the medication as well. If the patient can't afford their medication, doesn't have insurance, we make sure, that's the biggest thing that we focus in on particularly that medication, is making sure that the patient can get this medication before they leave home, go to a facility, so that way they can continue with their care. There's not a gap in their therapy. They get the full benefit on their medications. So we do those for acute medications, but we also do it for chronic disease states as well. So heart failure, COPD, are we optimizing their care in their therapy, and be able to make any alternative therapy changes, so that way the patient knows what they're going to be taking, as well as making it easier for the patients to stay adherent for their medications.
Great, thank you. And I know, I mean, C. diff is a devastating condition that patients suffer with, and so the pharmacists from your, team,
Yes.
are playing a critical role in addressing that issue. So, Stefan, maybe you could talk through some of the effective care model essentials and what you're doing in your practice setting.
Yeah, absolutely. Thank you. So I think, when you really think about how we can best care for patients, right? On the last slide, I talked about patient empowerment. So how do we give them the knowledge and the tools that they need to be successful with their therapies? And if you think about this here, when you talk about, empower, anticipate, and intervene with that patient. So I think for us, it's really helping that patient know how to best care for themselves and when to seek additional support. So like for us at our hemophilia treatment center, when you talk about timely initiation, that prior authorization, I know we've had in a lot of meetings the last 2 days that talk about the prior authorization process. We're fortunate enough where we have our own in-house team that does all the prior authorization work for us. And we have enough of the claims that are around the bleeding side, so of medications that are very costly, where we can get those really turned around very quickly so that we can have that no delay in treatment. And to your point with the meds to beds, I mean, when you get that patient the medication in their hand before they leave the hospital, you're really allowing them to have less barriers and then start their therapy right away and have that, like you said, have that no gap in care. Medication management and reconciliation. So my team is my pharmacy team is a multidisciplinary team. So I have, besides myself, I have 5 pharmacists, a nurse practitioner, 3 registered nurses, an dental hygienist, and 3 pharmacy technicians on my team. And if you think about bleeding disorders, it really takes that entire, collaboration between all of the different disciplines in order to make sure those patients are well cared for. From a medication management and reconciliation, we're really tracking every single time a patient calls in to get a refill, or if we're making an outbound call to them, we're asking them, have you been hospitalized recently? Have you had a bleed? Have you used your therapy at all? Are you maintaining your prophy? We're finding out how many doses do you have? And we actually do a calculation every year to show out of the doses we've dispensed, how many of those that we should have dispensed if they were getting their medication as they were supposed to versus what we do dispense. And then we're going back and tracking. So, okay, if there's a delta there, we're trying to figure out why. Did they miss their prophy doses? Do they have medication that might be expiring? All of those different pieces. And that education piece is just so critical. And I think that's where pharmacists really play a unique role, because if you think about it when you're first diagnosed or you're first in that physician's office, everything is, hurried, right? Like it's there's not a lot of time for them to spend with you. So when you're in that setting, you may have just received some news you weren't expecting, and you're in a place where you're not ready to accept that new disease state or new diagnosis. And when you get to the pharmacy and you talk to a pharmacist, hopefully you've had some time to kind of like reconcile with what's going on. And that pharmacist is there to really help you through that entire process by talking about not only your disease state, but the medication and the treatments and the side effects and everything that goes with that. And I'm very fortunate. So in my practice setting, I'm 50 feet from about 12 adult hematologists. On the way for me to walk past those hematologists, I go past our dental hygienist, our dietitian, our physical therapist. When I look at the seamless provider pharmacy patient loop, right, I have the ability to do that very easily. But I think it's extremely important that as pharmacists, we do in like a community practice setting or in the hospital setting, that we're really finding ways to share not just data, but relevant information to the providers so that they can make timely decisions on improving that patient's care.
Yeah. I mean, this is the concept that we're talking through. So some different settings of where pharmacists are touching patients, how the pharmacist can champion these medication-related issues. Again, it's not just about cost. It's about these medications have an expectation. How are we making sure that we deliver on that expectation? And then cost is a part of it. Obviously, we spend a lot of money on healthcare, and as the prior slide, like sick people are expensive. We want people to not be sick because it's, oh, by the way, they're human beings. Like we're talking about all of our family members, people that we know, people that we love. So when it's personal for us, it changes the lens, it changes the dynamic. And I think we also need to be reminded that when we talk about patients in these types of settings, that we're not losing sight of the fact that we're talking about actual human beings here, okay? So I mentioned Paragon. So Paragon Pharmacy, we utilize ScriptMed as our patient management platform, our pharmacy management platform. And that complements a system that we're building within our organization. We've built, we call it Modesto. And we are using Modesto to guide and manage this type of experience that we're talking about with our patients. So I'm going to touch on high-touch engagement and technology. And when we sit back and think about, okay, we're the pharmacist, we're dispensing these meds, we're opening up access to these medications, but we want to know if these medicines are working, we have curated an approach that involves accessing information from really 4 different sources. We hear a lot about proactive, like risk, like predicting risk and knowing this before it happens, kind of like Minority Report stuff. We have all this data that's telling us this is going to be an issue. We also don't want to lose sight of the fact that we don't necessarily, it's great to be predictive, but how about also you got to know what's going on with your patient. Okay, we're talking about real time, like these issues are happening now. It's not like they're going to happen in the future. We got a lot of information that's telling us that this medicine is not working now. So one of those 4 pillars, if you will, that we're using at Paragon, the first one is somewhat obvious, but it's patient-reported outcomes, okay? The patient can tell you if they're doing well or they're not doing well. We just have to ask them those questions and get that information, okay? So patient-reported outcomes is very key. The second is biometric information. The patient can tell you things by their data, okay? A lot of us have wearables. Most of us carry a cell phone in our pocket that is giving some type of health information about us. But we also have other devices like blood pressure cuffs that we can extract information, digital scales, pulse oximeters, you name it. There are a lot of different, what we call peripherals, that can extract biometric data and report that back to us via, seamless automated technology. The third area is medical data that comes out of the EHR, like laboratory values. So a patient gets blood work, that data is sitting somewhere, and we can get that. One of the places you can get it is through data stream. Inovalon has a pathway for us to get that data. There are other sources of that data. That's one of the areas we're using, is how do we get that data on medical patients and get them in our hands, because it can tell us whether they're good or not good. And then the fourth domain of data is the claims data. So patient has a health event and there is a provider that bills for a claim, that can inform us that there's an issue. Or if they get a prescription filled for a medication, that medication could tell us, hey, you know what, something may not be right for this particular patient. So in order to pull all of that together, we obviously need to leverage technology. And this is really where the technology becomes absolutely necessary, because the amount of information we're talking about is overwhelming on even one individual patient. But we can leverage the technology to do that. But as I mentioned, the patient data is very critical. So having a way to engage with your patients, talk to them in a manner that they want to be communicated with, like text messaging or video, or using AI agents, chat, to extract information from patients. Those are two areas that we are focusing on as a very core tenet, if you will, of this mission to monitor our patients effectively. And Stefan's going to talk about some of his examples, which he already began touching on, multidisciplinary
Yeah,
teams.
absolutely. Yeah, I'll continue talking about that. So, within our center, we're also very fortunate. We have a very large, we have genetic counselors, we have social workers, we have a lot of different people that we can have that help that patient. And, it talks on here about, having the reduced ER visits and admissions. I had to step out of the last call because the hospitalist that works for us at one of the local hospitals, he was calling me because we have a patient in the hospital that they can get out of the hospital if they can find the right place of care for him. So they're trying to get him into a rehab hospital, but the rehab hospital won't take them because they don't want to take on the risk of the high cost medication that the patient needs while they're there, because that's not something that they typically do. So I'm going to kind of tie that into my success story, because I think that this is very similar. So about 6 weeks ago, we had a patient who was in the hospital, very similar situation, was able to be discharged, but they needed to go to a skilled nursing facility. And the patient has Medicare, so in that situation, we are actually, as a hemophilia treatment center, allowed to dispense to that patient while they're there, as long as the skilled nursing facility agrees to it. And we can bill Medicare for that, and then they will not bill Medicare for the medication, obviously. So I reached out to a skilled nursing facility near that patient's home, was able to get a contract with that facility to allow us to dispense while they were there, and they were going to accept that patient. But there were a couple of things they needed before that they would be willing to take that patient. Number one, they've never infused factor to a patient before. Now, it's just a simple IV push, but that's easy for me to say because we do it all the time. So I was able to have one of our pharmacy nurses go to the facility and do an in-service with their staff and train their entire staff how to mix the medication that they were going to need to infuse, and then how to infuse it. I had a pharmacist call the pharmacy at the skilled nursing facility and talk to them about the proper storage, when to take it out of the refrigerator, potentially, again, how to assist them if they were going to be mixing the product. And then the patient needed physical therapy services, so I was able to connect them with our physical therapist, who provided them some guidance on what were the best exercises to help that patient regain mobility, but yet not overstress them and cause them to have a potential bleed that might have them be sent back to the hospital. So I think it's just, that was a huge win that unfortunately 3 years ago probably wouldn't have happened. And like when I call the hospitalist today, the idea is if I can help them get that patient out of the hospital, they might go home tomorrow. If not, they're gonna have to stay there till the second week of December, because that's how long their course of therapy on the other medications they need is gonna take them to complete. So it's, you're looking at a whole month of an extended hospital stay, which is gonna be an extremely high cost of care environment that we're trying to help reduce. And I think the other thing too is like when you look at reducing ER visits and admissions, so we actually have a third-party app that we partner with where patients can actually put into the app if they have a bleed or if they infuse factor. And then we can interpret that data and take that data in. And obviously, if a patient, is injured and we teach most of our patients, or as many as we can, to self-infuse. So we have kids as little as 6 and 7 years old that are able to self-infuse factor, so they don't have to go to a hospital. They don't have to go to an infusion center. So that's fantastic. But again, if they don't have the medication available to them in their home, now you're running the risk of putting them into another high care environment. So by making sure that we track when the patient uses factor, either through those conversations we have or using the app, we're able to help prevent them from going to the ER to get to an infusion that they already know how to do. And then also potentially, reduce admissions, right? Because most patients don't like going to the ER. I don't like going to the ER. It's not something that's on my to-do list. So if I was injured, I would probably do everything I could to avoid that, which means I might wait 2 or 3 days to go before I need to. And now I'm going to be admitted because my bleed is much worse than would have been if I would have been able to treat it right away. So I think those are a couple ways that we use technology and also leverage our multidisciplinary care team so that we can make sure that the patients have success. And I know, Megan, you were going to share a story as well.
Yeah, something similar. Actually, we actually had a patient who was in the hospital for an extensive period of time, for well over a month. And as they were slowly getting better, the one thing that kept them in the hospital was just a low platelet level. We had multiple different medications that were tried on the patient while they were there, and didn't have any success on moving the marker for a safe discharge. So we actually worked really closely with our hematology oncology specialist team to go in and see the patient, and actually decided that they wanted to start with a specialty medication. Well, specialty medications are very expensive, and not in the norm of a patient in the hospital. So this is where my team actually stepped in, looked into procuring the medication on the outpatient side to use as a patient-owned med. We worked with a specialty pharmacy, excuse me, to kind of see what the patient's insurance would be able to cover. Required prior authorization. The prior authorization keeps coming up. So we worked on that. Actually required several different documentations because they saw that the patient was in the hospital. We were trying to make a case to say if the patient can get started on the medication, then they could be potentially discharging from the hospital sooner. We did end up getting the medication to the patient. One of the other things too about the patient is that it particularly had to be a suspension too. Patient couldn't take any pills, and the suspension needed to be mixed. So I went in, talked to the family, be able to actually safely administer the medication that they would be able to continue using at home. So that way, in a sense, we're providing education to the patient and the family to be able to safely get them the medication. They were on it for a couple of days in the hospital and actually safely discharged within the next few days. So that's one of the successful stories that I have personally that showed that we were working very closely with a lot of different teams to be able to get this medication and actually get the patient out of the hospital sooner. A little side note on technology, just to bounce back. One of the things that our pharmacy has actually done in our outpatient side is to be able to, we've converted into a different software that actually allows us to do direct text messages to patients. I think that's honestly fascinates me because I've never seen that on a retail standpoint based off of my background. Easily a patient can just message the pharmacy, be like, hey, I need refills on the medication. And we can actually communicate in a secure chat, just letting them know, hey, this is what's going on, keep them updated on their medications that way.
Yeah, fantastic. Well, so I know, we're coming to the close here, and we're only really able to scratch the surface of this concept, right? There's so much involved in this topic that we're covering and addressing, but I think the point that I'm hoping that we leave you with is the role that the pharmacist can play in ensuring that we're looking in the right direction for what we should value out of a given medication. So we're going to go down the line and just leave you all with our parting thoughts and comments on what we think you should be really thinking about as you leave the session. So Stefan?
Yeah, so I'm gonna add two, because we kind of talked about this earlier, but it didn't come up naturally. So, yesterday during the opening session, it was discussed about burnout, right, across the different medical professions. And it was staggering to see that the pharmacist one was it like 50%? In the next 2 years are considering leaving the profession. And to me, that's, very, that's an outcome, right? Like the outcome is going to be, we're going to have not enough pharmacists practicing to take care of our patients. And I think when you think about just the way pharmacy has changed over the last couple of years, part of that is because of the commoditization of the product, right? It's not about the services that are being provided, but it's about the cost of the medication. So I think, having the data that we have is very important. But I also think too, there's a lot that goes into making sure that there's access to medications for patients. You talked about having to use copay assistance programs or compassionate programs with manufacturers. So I think my call to action would be, we talked about this already too, right? The data is great, but there's a patient at the end of it. And for me, it's how do we ensure that through regulations, laws, programs, that there's always access to the patients who need the medication the most. So the call to action would be to make sure you support those types of initiatives.
Yep, excellent. Megan?
Kind of bouncing off on that is that the fact that I'm able to practice a little bit differently than what the norm of pharmacy is just being able to actually be in front of the patient, being able to work on different therapies for the patient. I think my call to action to that is being able to actually see the patient as a patient, to have more empathy, be able to guide your therapy based off of what the patient needs. It's not just, we're just dispensing the medication, here we go, send you out the door. We're actually looking at what is all the patient needs in terms of financial access, transportation. We're looking at all these factors while we're seeing the patients in the hospital, so that way we can have a safe discharge for the patient. So my call to action is just looking at patients at a different perspective, looking at it more patient-geared therapy, as well as providing the resources that we need. Because, as you can see, we have to juggle between seeing all the patients versus actually dedicating our time and for the patients.
Great, thank you. My words, they really differ depending on who you are and what your role is in this healthcare system. You're all in some way, shape, or form touching the healthcare system. Payers, if I'm talking to payers, especially employers, self-funded employers, when you think about the healthcare payer world, it is shocking for any of you that don't touch the self-insured, self-funded employer plans. And I know a lot of the folks here are in government plans, health plans, Medicare, et cetera. It is startling how different government plans, Medicare plans, are from commercial plans. In the commercial market, it is completely devoid of any value-based, quality-based initiatives. And so I tell those folks, you need to leave here and demand more from the medications that you're paying for. And so I think the overall message that I want all of you to walk away from this with is that we need to all step up and make sure that, yes, we all have businesses, we all have jobs, we have a salary, we have income, we got to worry about these things. But we need to make sure that we're doing the right thing for our patients, and we need to hold medications accountable to efficacy and do our part to facilitate that in some way, shape, or form. I'm a business owner, and so and I think anybody who started a business or who is a leader in a business, I think there's a very common theme that we share, in that if you're chasing money, you're not going to be successful, because money is not enough to basically give you the motivation to endure the challenges of operating a company in the space. It is just simply not enough. It's challenging. And I think we need to unite around this concept that we all will say it either vocally or in the back of our head, that we're here to help patients. And my personal vision is I want to be able to build a business that takes care of a lot of people, and a side effect of that company is that it's financially viable and successful. And so I would encourage you all to share that philosophy and to take that back to your workplace settings and spread this, evangelize this concept of accountability to medication. And with that, I think we're out of time. I don't know if we have any time for anybody. If anybody has any questions, happy to entertain a question from the audience? No questions, I'm being told. Good off stage. All right. Well, thank you all. Appreciate it. Thank you to my co-panelists here. And hope you guys have a great day.